Hello everyone, and welcome to today's webinar with Dr. Timo Müller, who will talk about dual and polyagonists of incretins and related hormones as treatment strategy for metabolic disease. My name is Jenny Presto, and I am the Medical Science Liaison at Mercodia in Sweden, and I will be your moderator today. Dr. Müller earned his PhD in 2009 at the University of Duisburg-Essen in Germany and continued as a postdoctoral fellow at the Metabolic Disease Institute in Cincinnati. In 2011, Dr. Müller returned to Germany, and he is currently the acting director of the Institute for Diabetes and Obesity at the Helmholtz Center in Munich. Dr. Müller's research is focused on the development and evaluation of novel unimolecular polypharmacological options to treat the metabolic syndrome. Dr. Müller is part of an international team of scientists who pioneered the development of incretin-based dual and triple agonists and the targeted delivery of nuclear hormones using peptide hormone carrier. During the webinar, you will be able to write questions in the control bar to your right in your web browser. Your questions will be only visible for us organizing the meeting and for Dr. Müller, but not for all attendees. After the talk, if time allows, I will read the questions out loud on a first-come, first-served basis for Dr. Müller to answer. Questions that we don't have time to bring up will be answered through email. So, it is now an honor for Mercodia and me to give the word to Dr. Müller to give his talk, Novel Polypharmacological Treatment Options for Obesity and Diabetes. Please, Timo, the floor is yours.
All right, thank you very much, Monica, for this very nice introduction. It's a great pleasure for me here to be invited to give this webinar. It's the first webinar of my life, right? So I'm very used to give talks on international conferences, but it's the first webinar, and I'm really looking forward of how this is going. And today we are going to talk about novel polypharmacological treatment options for obesity and diabetes. I will now switch off the camera for a second, and then we need to restart the whole thing. And here we go. Okay, so just because it has to be here the conflict of interest, I received financial support or honorarium within the last 3 years from all of these companies, but I do not hold any stocks at any of these companies, nor do my family members, at least as far as I know. Okay, obesity is, as you know, one of the greatest healthcare challenges of our time. And you know that the prevalence of obesity not only increased substantially over the last decades, it also goes hand in hand with an increased prevalence of diabetes. And in Germany, at least, we like to look across the ocean to look at the prevalence rates in the United States, but we can also look in front of our own doors, and we see exactly the same correlation between the obesity prevalence and the diabetes prevalence in Germany. You see here on this slide that in Germany we avoid the red colors because we are sparing the red colors because we might need them later on, but the prevalence rates are almost exactly identical. Based on the World Health Organization, we can estimate that up to the year 2030, there will be every 7th person diagnosed with diabetes. And we know that obesity is the main risk factor for the development of type 2 diabetes. And when we look at what we can do to decrease our body weight, the most intuitive thing is to undergo a diet. And what you see here is that when we undergo a diet, we can maybe drop our body weight up to 6%, but the long-term prognosis is rather poor. If we combine our lifestyle modification, our diet, with pharmacotherapy, in this case orlistat, we can further drop our body weight up to 8 or 9% in the first year, but we have to note here that also here the long-term prognosis is rather poor. Of course, we can also undergo a bariatric surgery, and if we undergo such a surgery, we need to change the y-axis in order to display here the efficacy, because a bariatric surgery is far more effective in decreasing body weight as compared to what the pharmacology can do. And you see here that even after 10 to 15 years, you have a very good chance to maintain a lower body weight if you undergo a bariatric surgery. And what we learn from this slide here is two things. First, there is currently no pharmacotherapy that is able to decrease our body weight from what the pharmacology can do to what the bariatric surgery can do. And the second take-home message is that apparently one drug alone is not going to do the job, right? Pharmacotherapy, how many pharmaceutical companies actively worked in obesity research. We see here when we look at the picture of 1990 that a lot of pharmaceutical companies actively were working on the development of drugs to control body weight. If we look at the picture today, we see that most of them vanished. The reason why most of them vanished is of course different from company to company, but one of the things that certainly play a role here is that the regulation of body weight is extremely complicated, right? So in our brain, there are a lot of informations coming in from the periphery, and there is a bidirectional crosstalk from the periphery into the brain, and the brain connects all of these informations in order to increase or decrease our sensation to food, right? If we look at the history of weight loss pharmacology, we see that weight loss pharmacology is not new. We see here that the first pharmacotherapies that were used to decrease body weight were actually the use of thyroid hormone in the 1900s. And when you think about what happened at the 1900s, we see here that the year 1900 was associated with a dramatic increase of industrialization, right? And with the increase in the industrialization, there was a culture coming to Europe where being slim was a new way of how people needed to be. And if you wanted to be part of this culture, you needed to be slim in order to be hip, right? And when we look at the first pharmacotherapies that were used to decrease body weight, we see here, for example, 2,4-dinitrophenol. This is a substance that was discovered during World War I and was used to develop ammunition. It is basically a yellow powder, and it increases metabolic rate by uncoupling oxidative phosphorylation from mitochondrial ADP synthesis, right? The problem with 2,4-dinitrophenol is that the difference between the EC50 and the LD50 is just 2 to 3-fold, right? So if the patient doubles or triples the dose, it will result in overheating, fever, and death. And in the year of 1910 to 1920, which is the decade of World War I, we see that there are roughly 35, 37 fatalities attributed to the abuse of dinitrophenol. You see here that over the years, dinitrophenol was used for the control of body weight, and it was clinically developed in 1931 to 1940. And it then vanished in 1938 because the FDA prevented the commercialization of 2,4-dinitrophenol. But even today, you can buy dinitrophenol in the internet on the black market. And you can even today, we have from case to case some fatalities attributed to the intoxication with 2,4-dinitrophenol. Another thing that then was used to control body weight were the famous rainbow pills. I don't know whether you ever heard about these pills, but here is a commercial from 1945, and the rainbow pills were, so to speak, the first polypharmacological pills to decrease body weight. And what you see here is that these pills contained a mingle-mangle of substances that were known to decrease body weight. And in this case here, this contained amphetamine sulfate, thyroid hormone, and then a couple of substances that were put into the pills in order to mask the side effects. The rainbow pills caused more than 60 casualties, fatalities, before the FDA took the pills off the market in '68. The next drug that was used to decrease body weight was desoxyephedrine, and this is an amphetamine. And today you can still get this on the black market. We call it today crystal meth, right? So it's an amphetamine that has substantial side effects on the brain reward system. After amphetamine, there were the so-called amphetamine congeners. They were basically developed to maintain the anorectic effect of the amphetamines, but with far less side effects on the brain reward system. The caveat of these substances is that the weight loss capacity is extremely low, typically in the range of less than 5%. And this is the reason why the FDA restricted their use to only very short-term treatment. But still, there are a couple of congeners like phentermine that are still approved in certain countries for the treatment of obesity. Then we had the serotonergics like fenfluramine, sibutramine. They were later then withdrawn because of cardiovascular side effects. Then we had phentermine and fenfluramine as a combination, orlistat, lipase inhibitors, rimonabant, CB1 antagonists, also withdrawn because of side effects. And the drugs still in clinical use today contain cosumia, and lorcaserin activates the POMC neurons, the serotonergic receptor on the POMC neurons. And our latest achievement is Saxenda liraglutide 3 milligram is an agonist at the GLP-1 receptor, right? And because the efficacy of these drugs is so little, our lab based back then in Cincinnati, together with Richard DiMarchi, developed a novel strategy. And for those of you who have never heard about Richard DiMarchi, he's a biochemist, now with Novo. Back then he worked for Indiana University in Bloomington, and he co-developed Humalog, the first insulin pen. And our lab has a very long-lasting relationship, friendship with Richard DiMarchi, and we together developed a couple of drugs that I will now introduce to you. And one of these concepts that we developed together with Richard was that we take two naturally occurring hormones. One of them is decreasing food intake. The other one is increasing energy expenditure, for example. And we take the amino acid sequence of these two peptides and we fuse them into a molecule that is able to activate multiple receptors at the same time. And the first molecule that I want to show you is a GLP-glucagon dual agonist. So a molecule that activates both the GLP-1 receptor and the glucagon receptor. And the use of GLP-1 might be very obvious because GLP-1 is a known incretin hormone, right? So it acts on the beta cells to stimulate the secretion of insulin, has positive effects on the brain where it induces satiety, decreases body weight by inhibiting food intake. So GLP-1 was a very obvious candidate for such a drug, also because it's clinically used to treat type 2 diabetes. But glucagon is a very unintuitive drug to be fused with GLP-1. And before I explain you why we did this, we want to dive a little bit into the biology and histology of glucagon. And glucagon, the discovery of glucagon is very tightly connected to the discovery of insulin in 1921 by a team of scientists and surgeons in Toronto in Canada, comprising Frederick Banting, Charles Best, James Collip, and John McLeod. And in 1923, it was already published by Collip, right, the biochemist of this crew, that pancreatic homogenates cause a sudden surge in blood glucose before the induction of hypoglycemia sets in, right? And back then, the scientists considered this increase in blood glucose as a toxic side effect that results from a suboptimal purification of the insulin. And then basically two scientists, John Kimball and John Merlin, basically wanted to improve the method of how insulin can be purified from tissue homogenates. And they used different solvents to clear basically the pancreas and to isolate insulin. And what they came up with is a substance that was devoid of any effect to improve blood glucose, but they completely maintained the hyperglycemic effect. And they called the substance the glucose agonist, or shortly glucagon. In 1929, a couple of German clinicians then discovered that the rise in blood glucose is most pronounced if the insulin preparation is directly injected into the portal vein. So the substance apparently improved blood glucose or increased blood glucose via the action on the liver, right? And if the liver circulation is disturbed, the insulin preparation had no hyperglycemic effect. So apparently glucagon somehow acted on the liver in order to increase blood glucose. The peak of insulin-induced hyperglycemia was further dependent on the amount of glycogen that was available in the liver. And the conclusion was that the hyperglycemic effect of glucagon is partially mediated by decreasing the glycogen levels in the liver. And today, of course, we know that glucagon primarily acts on the liver to improve blood glucose, to increase blood glucose. And this is because it stimulates gluconeogenesis and stimulates the breakdown of glycogen of glycogen, and it prevents basically glycolysis, so the breakdown of glucose to pyruvate, right? Importantly, in animals that are hepatectomized, so that have not a functional liver, glucagon is incapable of increasing blood glucose. And in the 50s, there was a significant contribution of these two gentlemen here, Earl Sutherland and Christian de Duve, and both of them basically established that glucagon is produced in the alpha cells of the pancreas. Earl Sutherland, for his work on glucagon, received a Nobel Prize because he discovered the second messenger CAMP during his studies, and Christian de Duve received the Nobel Prize a couple of years later for the discovery of the lysosomes, right? And we know that glucagon comes from the post-translational cleavage of preproglucagon, right? So we have here preproglucagon, and this gets cleaved in a tissue-specific manner depending on the presence of either the prohormone convertase 1 or the prohormone convertase 2. In the brain and in the intestine, the prohormone convertase 1 cleaves preproglucagon into either GLP-1, GLP-2, oxyntomodulin, or glycentine, and in the pancreas, the prohormone convertase 2 cleaves preproglucagon to GRPP, or to also the glycentine-related pancreatic polypeptide, or to glucagon, or into the major proglucagon fragment, right? So glucagon is a molecule that is very well known to increase blood glucose, and there is substantial reliable literature that all shows that humans with type 2 diabetes have a hyperglucagonemia directly after the meal. So the glucose after a meal is incapable of decreasing glucagon secretion from the pancreas. And this can lead to a contribution of glucagon into the development of type 2 diabetes. So why did we now come out that adding glucagon on top of GLP-1 is beneficial for the treatment of diabetes? And before I answer this question, I need to say that working with glucagon is extremely challenging because glucagon forms these heterotrimers. So glucagon is insoluble at physiological pH, and this is the reason why the emergency kit of glucagon, which is used to treat hypoglycemia, comes with a lyophilized powder and a syringe carrying a solution that is very low in the pH. And the hypoglycemic patient needs to immediately solve the glucagon into an acidic solution. And even in this acidic solution, the glucagon is only stable for a few minutes because it gets hydrolyzed by the low pH of the solution. So the hypoglycemic patient needs to immediately solve this glucagon and needs to give himself an injection simply because glucagon is insoluble in water. And what we did together with Richard DeMarchi many years ago is that we took the C-terminal extension of exendin 4 and we moved this onto the sequence of glucagon. And when you do it as a molecule, we call it glucagon CEX for C-terminal extension. And this molecule is incapable of activating the GLP-1 receptor, but this molecule is water soluble. And when you put this molecule, this water-soluble glucagon, into a mini pump, you put it into a mouse, you see that this molecule has a very robust ability to lower body weight. And the body weight lowering is equal to the weight lowering effect of exendin 4, which is another paralog of GLP-1, which decreases body weight and improves blood glucose. And secondary to the weight loss, we see that the glucagon molecule is able to improve blood glucose. So chronic glucagon is able to improve blood glucose, decreasing body weight, right? And this was the idea of fusing both molecules into a agonist. And when we summarize it, we can say that it has a lot of beneficial effects on body weight and on system, which is that it acts in to induce satiety, to decrease food intake, and to increase expenditure. And it improves lipolysis in the white adipose tissue. Here's the molecule developed together with Richard. Here we see that the molecule carries an amino isobutyric acid at the second amino acid position. It carries a pegylation at the amino acid position 24, and the molecule carries a lactam bridge between the lysine at position 20 and the amino acid position 14. And when we compare this molecule to exactly the same molecule, but which has not the lactam bridge, then we see that the molecule without the lactam bridge is only activating the, whereas the molecule with the lactam bridge activates the GLP-1 receptor and the glucagon receptor. And the beauty of this is that we now have two molecules which are exactly identical in their PK, in their pharmacokinetics. So the molecule has the same half-life, same biodistribution, same in vivo potency, but one molecule, the blue one, activates both receptors. The one without the lactam bridge activates only one. The reason why the lactam bridge is so beneficial is because the folding of the molecule is so stable that the stabilizes the secondary structure to now activate both receptors. And when we look at this molecule, we see that the molecule has beneficial effects in lowering body weight relative to the which only activates the GLP-1 receptor. And we see that this molecule, in line with glucagon's ability to increase energy expenditure, has now the ability to increase energy expenditure coming from the activation of the glucagon receptor. In the liver, we see that the molecule has profound ability to melt away fat mass, and we see that this molecule is able to further decrease cholesterol levels. We further see, as we have seen it with glucagon alone, that also the dual agonist has profound ability to improve blood glucose. We see here that having glucagon activity on board of this molecule has no detrimental effects on blood glucose. We see it's actually beneficial. I had a postdoc in my lab, Christopher Clemensen, now working as a professor in Copenhagen, and he asked the question, does this molecule improve leptin sensitivity? You know that obese rodents and humans are insensitive to leptin. So what he did here is he induced a roughly 15% weight loss with this dual agonist, and then continued these animals either with the dual agonist alone, or he added leptin on top of the dual agonist. And you see here that when you give leptin on top of this dual agonist, you can further drive weight loss because these animals now start to respond to the leptin treatment. A sharp reviewer could now say, how do you know that the restoration of leptin responsiveness originates from the pharmacology and not from the weight loss? We asked exactly the same question, and this is answered in this experiment. In this experiment, we had several arms. Here we induced roughly 30% weight loss by exendin 4, or the same weight loss by calorie restriction, and then we added the leptin to these animals, and here you see that only these animals that received the pharmacology respond to leptin treatment, whereas those animals that lost the same amount of body weight by calorie restriction do not respond to leptin therapy. So the GLP-1 activation and the weight loss associated with GLP-1 pharmacotherapy improves leptin resistance, and this is independent of the weight loss. The drug also works in higher relative to treat with GLP-1 at a roughly 7-fold higher dose, right? The same.
Sorry for that. So the same principle was then adopted by multiple pharmaceutical companies. In this case here, we see GLP-1 glucagon dual agonist developed by MedImmune. They confirmed basically the beneficial effects of this drug. Several pharmaceutical companies have adopted the same system. Sanofi is now in phase 3 with their dual agonist. And you see here that a lot of pharmaceutical companies actively are now working on the same principle and are putting GLP-glucagon dual agonists into the clinic. The same here is also here a couple of human studies. We see here the MedImmune compound past phase 1, past phase 2. Here we see a couple of data. The molecule, when given to type 2 diabetic humans, has profound ability to improve post-meal tolerance and to improve body weight. We see that fasting glucose is lowered by the molecule and the HbA1c is improved. The next molecule I want to introduce is a fusion peptide between GIP and GLP-1. Before we talk about GIP, it's a little bit of a going back into the history. Why do we know that the pancreas is implicated in the regulation of blood glucose? Here we had two scientists, Oskar Minkowski and Josef von Mehring, and they took out the pancreas in dogs, and they showed that removal of a dog's pancreas immediately results in diabetes. And when they just ligate the pancreatic duct, this does not lead to diabetes. So they concluded that blood glucose is regulated through one or more factors that are secreted in the pancreas, from the pancreas into the circulation, and that basically affect blood glucose and then drives the development of diabetes. And the first hint on that there are intestinal factors that regulate blood glucose is coming from this gentleman here, Benjamin Moore, and he published almost 15 years before the discovery of insulin that when he takes intestinal mucosa homogenates and he gives this to diabetic patients, that he can reduce urinary glucose. And he suggested 15 years before the discovery of insulin that the intestine produces substances that act on the pancreas to stimulate a factor that then affects blood glucose. So he basically suggested the presence of incretin hormones way before the discovery of insulin, right? And of course, we know today that when you give glucose orally, you get a higher response in insulin secretion as compared to when you give the glucose into the circulation by injecting into the veins. And this is, of course, because these incretin hormones stimulate the pancreas to secrete insulin secretion, right? And GIP, previously known as the gastric inhibitory polypeptide, was first discovered by John Dupree and John Brown. And here they identified that this molecule increases plasma insulin levels in healthy humans. It was first discovered as a hormone that inhibits gastric motility. It was then later renamed to glucose-dependent pancreatic polypeptide. GIP is a very intelligent hormone because it not only increases the secretion of insulin, it can also increase the secretion of glucagon. And under hypoglycemic conditions, GIP increases the secretion of glucagon to increase blood glucose, and under hyperglycemic conditions, GIP increases the secretion of insulin to decrease blood glucose. So GIP is a very smart hormone, right? And if we remove GIP from gut extracts, and this was done by the lab of Roger Unger and Kreutzfeld, and then you can see that the incretin effect is just gone by 50%. So these guys here suggested that there must be another incretin hormone in the intestine, and this was then in '87 discovered as GLP-1, right? Okay, GIP, as mentioned, has its primary effects on the pancreas, where it stimulates, depending on the blood glucose concentrations, either the secretion of insulin or the secretion of glucagon, but it also acts in the brain. There are some recent indications that it activates the hypothalamus to induce satiety, but there are also some historical studies indicating that in certain cells, GIP can induce lipogenesis. So there is a little bit of controversy about whether GIP is good or bad, and you can read in the literature both that it's beneficial or detrimental. Here we show two molecules which are developed by us in collaboration with Richard DeMarchi. Both of them are pretty similar. Both of them carry an amino isobutyric acid at position 2 of the molecule to protect the molecule from being cleaved by dipeptidyl peptidase 4. The molecule carries the C-terminal extension from extendin 4, and the lysine at position 40 here at the C-terminal tail is amidated and either carries here a C16 fatty acid, or the amino acid position 24 is pegylated to delay renal clearance. And when we put this molecule into a mouse, here compared to liraglutide, both given at a dose of 30 nanomole per kilogram, we see that the GLP-GIP dual agonist is way more potent in decreasing body weight relative to the same amount of GLP-1, in this case liraglutide. We see that the dual agonist is way better in improving glucose tolerance. We see here in monkeys that the increase in blood glucose after a dextrose challenge is much lower after the animals have received treatment with the dual agonist. Here we see a phase 2 study published by us where we show that the molecule outperforms liraglutide in decreasing HbA1c. Very interesting in this study is the observation that we also observed that the molecule is able to improve cholesterol metabolism. This is a little bit unexpected because GIP or GLP-1 are not known to affect cholesterol metabolism. We repeated this then in the LDL receptor knockout animals, which have a lipoprotein profile that is pretty close to the humans. And we see here that GIP, here shown in green, has a very profound ability to improve cholesterol levels, namely LDL and VLDL in these animals. Also, this molecule has been adopted by the pharmaceutical industry. A lot of pharmaceutical companies develop their own dual agonist. The most famous currently on the market is the Lilly molecule, which I will show in a second, and they are currently entering phase 3 with this molecule. Here, a study recently published in the Lancet. This is a multiple ascending dose study. So we had type 2 diabetics that received different concentrations of the drug, so either 1, 5, or 10 milligrams, or the patients received for 2 weeks 5 milligrams, then for 4 weeks 10 milligrams, and then for the remaining period 50 milligrams. The drug was compared to dulaglutide, so a GLP-1 receptor agonist developed by Lilly, and we see here that the drug is able to improve HbA1c by up to 2.4%, so really a new landmark in the field. No other drug that I'm aware of is able to improve HbA1c in this magnitude. We see that weight loss is roughly 11% after 26 weeks of treatment. And when we look what is the percentage of patients that reach a certain weight loss level, we see that in only 2% of the patients treated with dulaglutide will lose more than 50% of their body weight, while between 20 and 25% of the patients that received the dual agonist can achieve a weight loss of 15%. Of course, we have to compare here the doses, right? The dual agonist was dosed much higher, but importantly, the dosage of GLP-1 is limited by gastrointestinal side effects, and apparently the patients tolerate much higher doses of the dual agonist as compared to the GLP-1 monotherapy. And when we compare here the side effects of the dual agonist given at 10 milligrams, we see comparable efficacy relative to dulaglutide. Right? So the side effects, you get the typical GLP-1 side effects. So the most prominent one are, of course, the gastrointestinal side effects, nausea, diarrhea, vomiting are the typical GLP-1 side effects. You see this here in the same magnitude with the 10 milligram dose as compared to dulaglutide with a much lower dose. So apparently the patients receiving this dual agonist tolerate a much higher dose of the dual agonist relative to the GLP-1 monotherapy. We also then developed a molecule that activates all 3 receptors at the same time. So the GLP-1 receptor, the GIP receptor, and the glucagon receptor. You see here that the molecule is even more fancy biochemical-wise as compared to both dual agonists. We see that the drug carries an aminoisobutyric acid at the second position to protect from degradation through DPP4. We see that the lysine at position 10 is decorated with a C16 fatty acid. The purpose of this is that this fatty acid binds to albumin to then delay clearance over the kidneys. And we see that the molecule carries the C-terminal extension from exendin 4 to improve bioavailability and improve solubility. And the C-terminal tail is amidated to protect the C-terminal extension from being degraded. This molecule is not only activating all 3 receptors at 100%, we were positively surprised that this triagonist also shifted potency in a magnitude of 10 to the left at each receptor, indicating that we have a super potent triple agonist, which shows full potency at all 3 receptors and 10-fold more potency at each of the 3 native hormones, right? So we would expect to be able to use very low concentrations of the drug to show dramatic effects on body weight. And this is what you see here. Here we injected animals, diet-induced obese mice with just 3 nanomole per kilogram per day, so a very, very little dose. No GLP-1 monoagonist would have an effect at this concentration. And we compared this to the GLP-GIP coagonist, and we see here that this molecule, which has also glucagon action on board, further drives body weight loss. A key question in pharmacology is always, where is the weight loss coming from? And here we see that the weight loss is exclusively coming from a decrease in body fat. We do not see a decrease in lean tissue mass, so we are not driving cachexia in these animals. We see that the molecule has the same anorectic effect, the same inhibition of food intake relative to the dual agonist activating the GLP and GIP receptors. So the consequence is that the additional weight loss has to come from energy expenditure, which is expected because of the glucagon activity, and this can also be measured in the laboratory. Here we see that these animals treated with the triagonist have a much greater energy expenditure relative to animals that are pair-fed to have the same body weight as the animals that receive the triagonist. The drug very nicely melts away fat mass in the liver, and also here we see a greater improvement in cholesterol levels relative to treatment with the GLP-GIP dual agonist. Also here we again see that having glucagon activity on board of this molecule is not detrimental for glucose metabolism. Solely the decrease in body weight is enough to here improve glucose metabolism, despite the fact that we have activity at the glucagon receptor on board of this molecule. Also, this molecule was then discovered in monkeys. Here we compared the triagonist given at a dose of 2 micrograms per kilogram against a 15-fold higher dose of liraglutide, and we see here that this molecule has a greater ability to improve body weight relative to treatment with a 15-fold higher dose of liraglutide. Also, this molecule is in clinical development. Novo has it in phase 1, and there are multiple other companies that have the molecule in clinical development. I just received note from Lilly that also they have a molecule in phase 1, and also Sanofi has a molecule. Oh, this is actually also phase 1. It's no longer preclinical. A key critical question is now, where do I think is the future going with this? And I would like to show you now in the last 5 to 6 minutes where I think will the coagonists be developed and in which direction this is going in the near future. And the next thing that we did also in collaboration with Richard DiMarchi is that we developed molecules that covalently link nuclear hormones, in this case here like estrogen, to the peptide hormone GLP-1. Estrogen and other nuclear hormones have a lot of beneficial effects on metabolism. Estrogen, for example, acts on the hypothalamus to improve energy expenditure and to decrease food intake, but it also acts in the pancreas to inhibit apoptosis of the beta cells and to stimulate beta cell survival and proliferation of the islets. And the problem of estrogen is that estrogen has detrimental effects in tissues like the breast tissue or in the uterus, where estrogen can cause cancer or proliferation of the uterus cells in order to induce hypertrophy of the uterus. And obviously, we want to keep the estrogen away from these tissues. And important is now that neither the breast tissue nor the uterus expresses the receptor for GLP-1. So the concept of this new drug is that this molecule binds to the GLP-1 receptor, gets internalized, and when it's inside of the cell, the estrogen leaves the mother peptide, penetrates the nucleus, and activates its nuclear targets. In the case of when the molecule is hitting a cell that lacks the receptor for GLP-1, then the molecule is not supposed to go into the cell, and the estrogen does not fall apart, and then we keep the estrogen effect away from those cells that lack the GLP-1 receptor. So it's pretty much a little bit like a Trojan horse strategy, where the GLP-1 is the horse, and the estrogen is basically sitting in the horse and needs basically the horse of getting into the city in order to get the nuclear hormone action going, right? So the critical question is, how does this work, right? And here is a study where we measured the stability of 2 molecules. We first made a stable ether-bound molecule. Here you see that when you incubate the molecule for 120 hours in plasma, you see only 1 peak indicating that the estrogen is not falling apart. And then we made a labeled ester-bound molecule, and here you see that after 3 hours in the plasma, you get a second peak indicating that the estrogen is falling off the molecule prematurely. And we tested these molecules in vivo in diet-induced obese mice, and you see here that only the stable molecule is able to improve body weight, it's not the label molecule, and it's not the GLP-1 given at this dose that improves body weight loss. And when we inactivate the GLP-1 in a way that the GLP-1 can still bind to the GLP-1 receptor, but does not get internalized, then we see that this molecule shown here in pink is incapable of decreasing body weight. So in order to improve body weight loss, we need an active GLP-1 along with the estrogen. And we see here that this molecule has profound ability to improve blood glucose, and it has profound ability to improve insulin sensitivity. And this molecule is devoid of any hypertrophic effects in the uterus. You see here the label conjugate where the estrogen falls apart prematurely causes very rapid hypertrophy of the uterus in the mouse. And this is not observed in those animals that receive the stable conjugate, simply because the estrogen is not able to go into these uterus cells because they are lacking the GLP-1 receptor. We also did a xenograft study where we measured tumor growth in these animals, and we see here that when we implant tumor cells into mice, we see that the stable conjugate is not able to increase tumor growth and tumor bearing in these animals. So apparently the drug does not hit the cells that lack the GLP-1 receptor. And also importantly, we analyzed the effect on the pancreas. Here we did a study in NZO mice, so a polygenetic model for obesity in mice. We see here the islets and the insulin-producing cells in green. And this is the condition when you put these animals on a normal chow diet. When you put these animals on a high-fat diet, you see that the estrogen-producing cells get less and less. So these mice develop glucose intolerant and lose their beta cells shortly on the transition from type 2 to type 1 diabetes. When we put these animals on a high-fat diet, not much happens. When we treat these animals with GLP-1, there's not much going on between the high-fat diet and the high-fat diet with GLP-1. But when we treat these animals with GLP estrogen, we see that the estrogen action in the GLP-1 receptor positive cells in the pancreas is able to stimulate proliferation and to inhibit apoptosis of the beta cells. So very beneficial effects on blood glucose. And with this, I'm already done. I thank you all for your attention. You can imagine there are a lot of people that I need to thank for all of these studies. Most importantly, my group here at the Helmholtz Center Munich, my long-term mentor, Matthias Czep, who together with Richard DiMarchi and his team largely participated in developing these drugs, and Heiko Lickert here from our Helmholtz Diabetes Center for helping with the islet studies. And with this, I'm done. I thank you all for your attention, and I'm happy to answer your questions.
Thank you very much, Timo. This was a really interesting and a thorough talk about the agonists and the incretins and the different hormones you can use for hopefully giving a better treatment for obesity and diabetes. I'm giving the attendees a little bit more time to write down questions if they have any. But meanwhile, maybe I can start with a few questions.
Yeah.
So the first questions we are thinking about is, what do you think, what would it take to get the same weight loss in humans using pharmaceuticals or these analogs as to get the similar results as bariatric surgery? Will it be possible?
Well, that is actually a very good question. I think given the fact that the bariatric surgery is so sustainable in improving body weight, it is very unlikely that this is simply because of the rerouting of the intestine or cutting off 50% of your stomach, right? So it is extremely likely that there are endocrine changes in the body after the surgery that explain the metabolic effects of the surgery and also the sustainability of the surgery. So we pharmacologists, we have a real hope that understanding these endocrine changes after the surgery can help to develop drugs that mimic the surgery in a comparable manner. There are pretty good data showing that it is not simply the cutting off of the stomach or rerouting the intestine. So there must be endocrine changes that help to explain the efficacy and sustainability of the surgery. So I strongly believe that we will be in the future able to develop drugs that bring our body weight very close to what the surgery can do. Maybe not exactly the same, but the new drugs already improve weight loss far more than what we ever have seen with previous drugs, and apparently also safer as previous drugs. And I have a strong hope that this will further continue, maybe with the nuclear hormone conjugates, to develop drugs that bring the weight loss close to what is possible with the bariatric surgery.
Thank you. That sounds promising. You have talked about GIP and GLP-1 as the incretins that you are targeting with your treatments, and then you added estrogen to the GLP-1. Are there other types of gut hormones or other hormones in the body that you think should be tested or have potential?
Oh yeah, I mean, there are a lot of gut hormones that have therapeutic implication. FGF21, for example, is one of those. FGF21 is mainly secreted by the liver under conditions of enhanced fatty acid oxidation. And FGF21 primarily acts on the brain to increase energy expenditure. And there are a lot more gut hormones that have a therapeutic implication. Amylin, for example, right? We know Symlene, is an amylin analog, and acts on the liver to shut down gluconeogenesis and decreases glucagon secretion, and also acts on the brain to induce satiety and decreases food intake. So there are a lot of gut hormones that have therapeutic implications. The only thing is you probably need to make them more long-acting, because many of them have very specific effects in the intestine, and only a very short portion of the active drug reaches the brain. For example, GLP-1, there is an estimate that less than 5% of L cells secreted GLP-1 reaches the brain. So making a long-acting GLP-1, like liraglutide being one of the first ones, is certainly beneficial. And we have now learned that biochemical modification of gut hormones carries great pharmacological potential for the development of novel drugs. And we have seen already a couple of those coming. For example, amylin is in clinical use, and there will be more coming in the future. And combining now multiple of these gut hormones into dual agonists is certainly another chapter that turns out to be very fruitful for the development of novel drugs in the future.
Thank you. So now I will continue with a question from Martin Maro in the audience. What are your thoughts regarding the controversy behind GIP receptor antagonist and agonist for weight loss?
That is actually a smart question. And of course, I come from a lab where GIP activation is sold as a mechanism to improve diabetes. But I personally know a lot of people that published that GIP antagonism can do very good things on metabolism. And I think both sides have reliable data to rely on. I know that MedImmune has a GIP antagonist in clinical development, and they wouldn't do this if they wouldn't have positive data from the preclinical data. I also know that type 2 diabetic humans are often resistant to GIP action, and my take why the dual agonist from Lilly or also our GLP-GIP dual agonist is doing so well is because GIP is a very powerful incretin hormone, but it requires low glucose levels in order to do good. And the GLP-1 is decreasing blood glucose to a point where the GIP is adding extremely beneficial effects on top of GLP-1. And this is, in my opinion, one of the reasons why the GLP-GIP dual agonist is doing so much better as compared to GLP-1 or to GIP alone, simply because humans have a tendency to respond very little to GIP. And this was shown by Michael Naub, for example. But when you have GLP-1 on top of this, which decreases hyperglycemia, then the GIP can fully act as an incretin and improve insulin sensitivity. But to come back to the question whether I believe more in GIP agonism as antagonism, it looks as if this is almost a religious question, and I think there are reliable data on the market that indicates that both of it can have beneficial effects. So as a biologist, you can almost say it doesn't matter what you do, whether you activate or deactivate GIP, as long as you're doing something with GIP, it's good.
Thank you, interesting. A second question from Vic Ben Ezra in the audience is, could you comment please on the function or involvement of GLP-2?
Oh yeah, that's actually a good question. So GLP-2 is co-secreted with GLP-1 from the L cells, right? And GLP-2 has very little effects on the brain. It acts primarily in the intestine to affect GI motility, right? So GLP-2 inhibits GI motility in the intestine, and there are very little metabolic effects of GLP-2. But we have a couple of projects going on with GLP-2 as well, and we are also using GLP-2 as a potential tool to develop certain drugs into the intestine. But GLP-2 has very little effects on metabolism that go over the brain.
Thank you. Let's see if the audience have any other questions before we end this. I have one additional question. It is about the agonism of GIP, for example. How does that affect when you treat with pharmacological levels? How does that affect? Do you get any effect on bone formation, for example, or other side effects, or is it too low to give any other effects?
Yeah, that is an interesting question. I have to say that we never measured bone formation after GIP agonism alone. I'm not aware of any extremely detrimental studies that have ever shown this. GIP does have effects on the bone, but I'm not aware of preclinical studies, for example, also with the dual agonists that have ever shown that there are detrimental effects on the bone. So I'm not aware of any detrimental effects on the bone.
No. Okay, thank you very much. It doesn't appear as we have more questions at this moment. If someone in the audience come up with a question later on, you are very welcome to email me and I will forward it to Dr. Müller for him to answer afterwards. And so with that, I would like to thank you very much, Dr. Müller, for this great talk. It has been really interesting. And I also want to
thank you very much.
Thank you. And I also would like to thank the attendees for today. Very nice to have you all here. So by this, we end the session.
Thank you very much.
Thank you and goodbye.
Bye-bye.